Hi, all. Welcome back to Revise Mat. Today we will be dealing a new topic, that is how to approach abdominal pain in an SLE patient. It's a small topic. Let's get into the topic. So when you planning to approach a patient with an abdominal pain, history is your first tool. You have to do a detailed history before ordering investigations in this patient. So you have to ask whether the onset and nature of the pain, whether it's a colicky, sharp or dull or burning type of pain, whether it is continuous pain, because that's a more important type of pain, and whether the relationship of the pain with the intake of food, whether the pain is worsening after meals. It is more suggestive of a lupus enteritis or mesenteric ischemia, can also be associated with an ulcer. You have to also ask about the other associated features like fever, vomiting, diarrhea, constipation, any rashes or urinary symptoms, because you have to assess whether the patient is having any active SLE or infection, and the usage of past as well as the current immunosuppressive drug, the dosage, at what level he is getting the immunosuppressive drug. So these are very important for the initial evaluation of a patient who is coming with an abdominal pain in case of SLE. What is our most important job as a physician or as an emergency physician is to identify the red flag signs. So if the patient is having abdominal pain which is sudden and continuous pain, we should be very alert. Similarly, those who are presenting with GI bleeding, guarding or having rigidity on examination, and associated with vomiting along with hypotension and any signs of sepsis, because these warrant urgent resuscitative measures as well as empirical treatment. If the patient is having any of these symptoms, just go for CT abdomen. Don't wait for any other investigations. Directly you can do the investigative modality, that is CT abdomen, for this patient. So let's look into the causes of abdominal pain in SLE. It can be divided as lupus related causes and lupus unrelated causes. So most of the lupus related causes usually will be associated with high disease activity and will respond to immunosuppression, of which most dreaded complications associated with lupus related abdominal pain is the mesenteric vasculitis, mesenteric thrombosis, and lupus associated pancreatitis and lupus enteritis. One of the most important is the lupus enteritis, and the other causes can be lupus peritonitis, pseudointestinal obstruction, veno-occlusive diseases, Budd-Chiari syndrome, lupus hepatitis. And lupus unrelated causes will be usually seen in patients who are taking high dose immunosuppressive, who are compliant to the drug, and usually will have a stable lupus activity. That can be due to peptic ulcer disease, drug-induced gastritis, GI infections or urinary tract infections, nephrolithiasis, adrenal insufficiency, especially in patients who are stopping the drugs, who are already on steroids and they have stopped, or sudden withdrawal of steroid can cause adrenal insufficiency, and atherosclerosis of abdominal aorta, and can be associated functional diseases such as irritable bowel syndrome. So these are the causes of abdominal pain in SLE. So coming to the investigative modality, all patients who are presenting with an abdominal pain should get an X-ray abdomen that should be taken in a erect posture unless it is contraindicated, to rule out any perforation or obstruction. And ultrasound should be done in all patients. CT abdomen is the gold standard for those who presenting with abdominal pain. It picks up lupus enteritis. In CT abdomen, you can see a target sign, and in case of pancreatitis, both for diagnosis as well as for risk stratification. And in case of mesenteric vasculitis, you can see comb sign. And in case of thrombosis and Budd-Chiari syndrome, also you will get an idea in CT abdomen. Even multiple infarcts such as splenic infarct also can be seen in CT abdomen. When you are considering the imaging modality, any patient with a red flag sign or symptom with abdominal pain in SLE, don't wait for X-ray abdomen or ultrasound. Go straight for CT abdomen to rule out the emergency causes. This is the one of the simplified approach in case of abdominal pain in SLE. So after history as well as initial evaluation, you have to do USG abdomen or CT depending on whether they are having red flag signs or not. If they are having red flag signs, don't wait for USG or X-ray, go for directly CT abdomen. As the blood investigation, you have to do liver enzyme, bilirubin, serum amylase and lipase, and take an X-ray erect, that is in standing. If you are suspecting UTI, do urine culture and ascitic ADA if you are suspecting tuberculosis, and you can add. If if you are getting a normal or mildly raised liver enzyme with ascites, then think about lupus peritonitis. If you are getting a raised liver enzyme along with ascites, along with venous thrombosis on Doppler, think about Budd-Chiari syndrome. If you are getting an raised amylase and lipase along with an ascites with a bulky pancreas on USG, think about acute pancreatitis, which can be SLE associated or drug induced. Do a CT to confirm pancreatitis. If you are getting a borderline elevation of enzymes with an inconclusive USG, that is, there is a bowel wall thickening or dilatation, don't wait for other investigation or blood test. Just do CT, because we have to find out the emergencies such as mesenteric vasculitis, lupus enteritis, and thrombosis. In case of mesenteric vasculitis, you can see a comb sign. Lupus enteritis, you can see target sign. So what is lupus enteritis? Lupus enteritis usually affects small bowel and presents with pain, ascites, vomiting, as well as diarrhea. The imaging shows bowel wall thickening along with dilated loops, and you can see target sign in some patients. And it responds well to high dose steroids and cyclophosphamide. It is an emergency and you have to treat very fast. Next is the lupus peritonitis. It is actually rare and usually occurs during the early part of the flare, and it usually resolves also. In case of chronic cases, it can cause adhesions. Coming to pancreatitis, usually pancreatitis in SLE will be associated with a high disease activity or associated with a high disease flare. Isolated pancreatitis in SLE is very rare, and it can be seen up to 4 to 10% of SLE patients. That is, it can be associated with steroid induced or disease related, such as high disease activity, and it is usually treated with steroids and immunosuppression if there is a high disease activity. If the disease activity is stable and if it is probable due to drug induced, withdrawal of the drug is the culprit drug is the treatment. And always watch for the risk factors for pancreatitis such as hypertriglyceridemia, psychosis, and pleurisy. If the patient is having these hypertriglyceridemia, psychosis, and pleurisy, they are more prone for having a pancreatitis. So treatment is tailored to the specific etiology. The primary approach involves immunosuppression for the disease activity and targeted therapy for the complication. So if the patient is having vasculitis or pancreatitis, it is due to the disease activity, or you have to treat with high dose IV steroids with cyclophosphamide or MMO, depending on the clinical context. If they are having lupus peritonitis or mild hepatitis, treat with steroids along with azathioprine or methotrexate. If it is due to veno-occlusive disease such as Budd-Chiari syndrome, anticoagulation is needed unless it is contraindicated. If the patient is presenting with pseudo-obstruction or known as Uglies syndrome, the management is conservative management along with continuation of immunosuppression. If the patient is presenting with drug-induced gastritis or pancreatitis, the treatment is to stop the offending drug. So with this, we conclude our session, and always remember that abdominal pain in SLE or lupus is never simple. Always combine clinical clues, imaging, biochemical markers, and always assess the global disease activity to arrive at the diagnosis. So with this, we are stopping this session. If you found this video helpful, hit like and subscribe and share with your fellow medics. This is Rahul from ReviseMed, making rheumatology simpler, one topic at a time. See you in the next video.